Welcome to PharmacyToDose, the Critical Care Podcast. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. QXMD builds mobile solutions that drive evidence-based care in clinical practice. So check out Read for easy access to research personalized for you. Calculate for over 500 easy-to-use decision support tools, and Learn to earn CME online in minutes per day. Try them today at qxmd.com/apps. Again, that is qxmd.com/apps. Well, 'tis the season to certainly say what you are thankful for, as we're recording this right after Thanksgiving. And I've said it before, and I'll say it again. I'm so thankful for each and every one of you, the friends of the pod, from being a guest on an episode to telling your peers and colleagues about the pod to hearing stories about how you all appreciate or how it's helped you learn a specific topic. It all legitimately makes my day. It's all humbling, and I really just wanted to take a quick second and just remind you all of how much I appreciate all of you and your support. And so excited for today's episode. As I said, we're recording this the day after Thanksgiving. And so for many, this topic may be extremely timely. And I keep working on ways to kind of implement new creative kind of activities or things within the podcast to make it a little more interactive. And this episode tries something new. So I'm joined by Kent Owusu to talk all things alcohol withdrawal. Now, Kent and I created a survey and a poll on social media and a pharmacy listserv to try and get a better idea of how the listeners manage alcohol withdrawal disorder. So we'll be including and kind of dissecting some of those results throughout our episode. Now, our special guest today, Dr. Kent Owusu, received a Bachelor of Science in Biochemistry and Biology from Florida State University in Tallahassee, Florida, and a Doctor of Pharmacy from Auburn University. Subsequently, he completed a PGY1 pharmacy practice residency and a PGY2 critical care specialty residency at Yale New Haven Hospital in New Haven, Connecticut. Additionally, he is board certified in pharmacotherapy and critical care. Following his residency training, Dr. Owusu spent several years practicing as a clinical pharmacy specialist in neurocritical care and served as the residency director of the Emergency Medicine Specialty Residency Program. He serves as an adjunct faculty for the University of Connecticut and University of St. Joseph's Colleges of Pharmacy, in addition to providing lectures for the Yale School of Medicine Advanced Practice Provider, or APP, pharmacotherapy courses. More recently, Dr. Owusu transitioned into a more integrated role within the Yale New Haven Health System as a lead for care signature and lead system initiatives aimed at reducing clinical care variation by the development of clinical pathways for service lines. Kent, thank you so much for joining me. How was your Thanksgiving?
Nick, thank you for having me. I am still trying to recover from my food coma from yesterday. My Thanksgiving was great. Spent it with my sister and nephews. So very small, but we're grateful for so many things in this day and age.
Oh, absolutely. Now you got to let the listeners in. How many plates did you get when the meal kind of came out? We're excluding leftovers at the moment.
So I think if full disclosure, I think I had 3.5 full plates, not including desserts. So yeah, I think I overdid it for sure.
Well, if there's any time to do it, it's on Thanksgiving. It's my favorite holiday. It's a day of being around, right now, your close, immediate family. You get a big meal, you fall asleep to some football, you start getting in the holiday mood. I think it's just the absolute best.
Yeah, and what's interesting is that because my family, so my background is Ghanaian, so we do a hybrid Thanksgiving where we do the traditional turkey and all of your regular sides, but we also put in some traditional African dishes. So it's almost double the amount of food you would expect to eat. So it's certainly no joke. And I agree, if any time was the right time to overeat, this was definitely it.
That's awesome. I love when families and people, they create their own kind of rituals and things for Thanksgiving. And so kind of adding in some of the native dishes and bringing in some of the kind of your local African cuisine and things sounds like just an absolute awesome twist to an even better holiday.
Yeah, and it gives you more excuses to continue to eat until you can't eat more.
Now, like I hinted at in the introduction, I think a lot of people not only may have indulged in some food, but also some beverages, right? It's holiday heart season here. So we're talking about alcohol withdrawal disorder. Now, before we kind of get into the nitty gritty and talk about all of it, I guess, why do we even care about alcohol withdrawal? And what consequences can occur that make this a syndrome or disorder that we recognize and try to treat as quickly as we can?
So, Nick, that's a really interesting question, because actually, after nicotine, alcohol is the most commonly abused drug globally. Ironically, though, it wasn't until the late 1950s, so not too long ago, that alcohol withdrawal disorder was actually shown to be a physiologic manifestation of abrupt reduction in the amount of alcohol that one has been consuming. So as you can imagine, Nick, that's not very long ago. And in terms of consequences, alcohol withdrawal disorder can vary in severity, and oftentimes it can make the care that we provide for our patients very complex and complicated. It can also increase the morbidity in critically ill patients. So if we don't pay attention to this, you can imagine how that can negatively impact the quality of care we provide to our patients.
Now, how do we diagnose or recognize alcohol withdrawal disorder?
So recognizing alcohol withdrawal disorder can be tricky, especially when it presents similar to other clinical conditions that our patients may present with. There are different types of alcohol withdrawal, and the symptoms may range from mild, where a patient may exhibit jittery movements and sometimes nausea, diaphoresis, or sweating. And then the patients might also present with more severe symptoms such as seizures and death in some unfortunate cases.
Now, are there different types of alcohol withdrawal, or is it a little more kind of cut and dry, where you have alcohol withdrawal disorder or you do not?
Yeah, there's certainly different types of alcohol withdrawal, and perhaps we can get into some of the physiology and what is happening when someone who has consumed either acute or chronic amounts of alcohol. So maybe let's get into that. So a few things we know. So first, we know that GABA, specifically GABA A receptors and NMDA receptors, play a critical role in the complex pathophysiology of alcohol withdrawal disorder. We also know that during the acute ingestion of alcohol, these NMDA receptors, which are excitatory in nature, become inhibited. And during this time, your GABA A receptors, which are inhibitory in nature, are stimulated. So in the acute scenario, Nick, this leads to anxiolytic and sedative effects from parts of the brain, including the cortex and the brainstem. And we know that the brainstem includes the midbrain, which is continuous with the thalamus. So I say all this because the distribution of these receptors, specifically the GABA A receptors in the brain, influences the manifestations we see when patients are going through withdrawal symptoms, which include seizures. During chronic alcohol use, however, the GABA A receptors are downregulated and the NMDA receptors become upregulated, and this happens to maintain CNS balance. So when all of a sudden there is no longer alcohol in the system, these compensatory mechanisms are all of a sudden exposed. So now you have an increased function of your excitatory receptors, and there's a subsequent increase in the glutamate binding to these NMDA receptors. At the same time, the inhibition provided by the GABA A receptors is reduced, so now you also have autonomic excitability and psychomotor agitation. In terms of the time course, I believe, alluding to your initial question, the mild symptoms such as the autonomic symptoms, your headache, tremors, anxiety, sometimes insomnia, may be observed as early as 6 hours after the last ingestion, whereas seizures and other more severe symptoms usually occur no sooner than 12 to 48 hours. Additionally, Alcohol hallucinosis can be an early symptom, and with that regard, the visual symptoms usually occur more commonly than the auditory symptoms. Finally, Nick, delirium tremens or DTs usually begin about 3 days after the appearance of the initial alcohol withdrawal symptoms, and this may last for 2 to 3 days or even longer in some cases. So I hope that I painted a picture and highlighted the timeline, which hopefully can create some justification for the prompt recognition of the symptoms early on, but also to allow for the management and prevention of the further worsening of these symptoms.
Well, not only do I think you created a great timeline, but I think you also highlighted how challenging it can be when symptoms can manifest from 6 hours to 72 or even longer hours after, alcohol cessation or reduction. So, kind of showing how challenging it can be and how people may present wildly differently and how that can kind of complicate some of our management. Now, ultimately, when we're treating, alcohol withdrawal disorder, what's our treatment goal? What's our ultimate thing that we're trying to do here?
Yeah. So ultimately, Nick, the treatment goal is to reduce the frequency and the duration of the symptoms highlighted before. So we want to make sure that the symptoms, if they do persist, are not hanging on for too long, because there is subsequent sequelae that can occur with the longer the symptoms last. We also want to make sure that we prevent seizures and other severe symptoms that might come along with the alcohol withdrawal disorder. And finally, we have to make sure that the treatments that we're using are not causing more harm with the drugs that we're selecting. And given the pathophysiology of the syndrome, the drug therapies that we use are targeted usually to activate the GABAergic pathways and or reduce the excitatory or the NMDA activity that we talked about previously.
So today we're focusing on alcohol withdrawal, but let's talk about a situation that I think many have encountered or at least received a question about prior to patients experiencing withdrawal. And I think our surgical colleagues probably maybe relate the most to this. But should we ever give someone alcohol, whether it's wine, beer, liquor, what have you, as an inpatient to prevent alcohol withdrawal?
So, this actually comes up every now and then. And there is tremendous variability in the kinetics of alcohol metabolism, especially in chronic users and in patients with liver disease. Additionally, there is a host of reasons why alcohol use for the treatment of alcohol withdrawal disorder is not a great idea. So let me give you a few of those reasons. So first, ethanol or alcohol has a much shorter duration of action, right? So that means you have to administer it multiple times at multiple frequencies, and you can see how this could be challenging for pharmacological care. Ethanol has a super narrow therapeutic window. Alcohol can lower the seizure threshold. It irritates the gastric mucosa. It can cause fatty liver. It can worsen hepatic failure. It can lead to accumulation of toxic metabolites such as acetaldehyde. It can cause excessive sedation, which we don't want in our patients usually. It can also cause respiratory depression, especially in elderly or patients with organ dysfunction. You can also throw in a host of drug-drug interactions. Let me say that one more time for the people in the back. It can have a host of drug-drug interactions, right? So if all that is not convincing enough, Nick, there's been studies that actually compared alcohol or ethanol to current therapies, including benzodiazepines. And these studies, time and time again, have shown that ethanol has no advantage over our conventional therapies, and it has worse side effects. Additionally, prescribing alcohol for a patient with alcohol dependence sends the wrong message that they have a clinical permission or justification to continue drinking, and that it is acceptable and not harmful to their health. So in summary, ethanol, whether it's wine, beer, whiskey, is not appropriate for the treatment or prevention of alcohol withdrawal. And I hope I made a good case of that.
I think you absolutely did. I think one of the big points you highlighted is that it sounds like we really have no idea how people are going to respond. And somebody can claim they have a really good, safe way of managing it that may have possibly worked for one patient in the past. That's absolutely true. But that might have catastrophic problems or failures for the next two people you try it on. And so it's just, at the end of the day, we're always trying to, number one, first do no harm, right? And I think that's one of the big points here against that.
Absolutely.
So almost everyone listening is probably familiar with the fact that symptom-triggered treatment strategies with benzodiazepines are commonly used for the treatment of alcohol withdrawal. But Kent, give us a little insight into why we do this and what has this symptom-triggered treatment strategy been shown to do?
Absolutely, Nick. So as you mentioned, different benzodiazepine strategies have been studied and utilized in patients with alcohol withdrawal disorder. This has included front-load dosing, fixed or scheduled dosing, and as you highlighted, symptom-triggered management, meaning only given doses of benzodiazepines or medications when patients exhibit symptoms typically determined by a type of withdrawal or sedation scale. Among these strategies, symptom-triggered treatment is often favored because it has shown time and time again that when you utilize this approach, you end up using less amounts of benzodiazepines, but also a less duration of therapy overall. And as you may recall, that's one of our treatment goals when we're managing these patients. We know from the data from the original Decarolis studies in 2007 that in addition to other studies, including one using chlordiazepoxide with a symptom-triggered protocol, these strategies have been shown to decrease the number of benzodiazepines that we provide to our patients, as well as the overall duration of treatment. The one critique, however, with symptom-triggered management approach is that you may undertreat the patient's alcohol withdrawal disorder symptoms, and in some instances, overtreat when patients' symptoms present similarly to other clinical syndromes. You highlighted that we performed a survey through a critical care listserv, but also on social media. And this survey highlighted that about 60%, so with the critical care listserv respondents, that was 39 out of 65 respondents utilized a hybrid approach, meaning scheduling benzodiazepine therapies with superimposed symptom-triggered therapy. Now, this may be reasonable as it provides a proactive approach in treating alcohol withdrawal disorder. However, it may also lead to unintended consequences, including dose stacking and an increase in side effects, especially when agents with different pharmacokinetic properties are utilized concomitantly.
And this was one of our, we talked a bit about at the beginning where we created a survey to try to get an idea of how some of the listeners and our peers and colleagues were helping manage alcohol withdrawal disorder. And, you touched on the two top answers in both the Twitter poll and kind of the listserv survey that we sent out, where it is, in one symptom triggered was number one and a combination was number two, and then vice versa, it flipped for the other. So these are the most common kind of, strategies from the people that we polled. Now, I really like the idea of doing symptom triggered for the first 24 to 48 hours, get an idea of what their requirements are, and then trying to start the fixed dose to help titrate off as they're out of that acute phase. That tends to be, at least from my very limited experience, what's worked well. But obviously there's many different ways to kind of practice here. Now, when we're thinking of which benzodiazepine to use, what are some considerations that we need to try to keep in mind?
That's a good question, and I say there's no straightforward answer. So, Nick, there are different considerations for the benzodiazepine selection, as you highlighted, and we know that no specific benzodiazepine is superior over the other for the management of alcohol withdrawal disorder. So selecting an agent should be based on the drug-specific properties, including its pharmacokinetic properties. Longer-acting benzodiazepines such as chlordiazepoxide or diazepam may offer a smoother withdrawal upon cessation due to its long half-life, and may be more ideal when using a loading dose because the long half-life is not going to be a concern in this scenario. This would be ideal example in patients with neurologic injury. Shorter-acting benzodiazepines such as lorazepam, however, offer less risk over sedation, which may be ideal in patients who are elderly or those who have liver impairment. You also have considerations for benzodiazepines that have rapid CNS redistribution, such as midazolam, and this may also be more ideal in patients with neurologic injury or even in your general critical care population when a continuous infusion is desired. However, it's important to note that midazolam does have active metabolites, including an alpha hydroxy metabolite, which may accumulate in patients with renal dysfunction. So generally, if a short-acting agent is used, the risk for developing tolerance for shorter-acting benzodiazepines in patients with severe alcohol withdrawal syndrome needs to be considered, and a continuous infusion may be needed in some of these critically ill patients with severe symptoms. As I alluded to earlier, Nick, alcohol affects the conformation of GABA receptors, and as such, benzodiazepine tolerance might develop, especially with these shorter-acting agents. So it is very important to incorporate objective assessment tools and also to allow for ample time to assess the drug effects so that one can determine the need for additional doses, especially if you're using something like a symptom-triggered approach, or also determine the need for alternative dosing strategies when you feel like your benzodiazepine therapies are not working.
Let's put a pin in that kind of last statement, because that's a perfect kind of lead in into kind of like my next question. But I wanted to highlight, as we're, as COVID is starting to, increase and has increased in kind of across the country, and as people are dealing with drug shortages, I think those are really important pearls to keep in mind, so that when we have to switch from maybe the agent that we're used to using, that we can make sure that these patients are still getting kind of safe and effective therapy.
Absolutely.
And so you were hinting on the fact that you, depending on, your dose may need to change, or your patient may not necessarily be responding to the treatment that you're using. So a common scenario that can happen is patients who are in benzodiazepine resistant alcohol withdrawal. So how do we know if a patient is kind of experiencing this? And I'm asking because when you're dealing with resistant alcohol withdrawal, we may need to use larger benzodiazepine doses than we typically would. And I think these larger doses may lead to provider discomfort with not only ordering, but also administering some of these regimens.
I think it is very tricky because there is no gold standard as to a time point universally to assess when one is going to respond to the general class of benzodiazepines, right? So as I alluded to earlier, I think it is important to understand the kinetics of the drug and when you would expect an onset of action and how long the drug is going to last. But it's also important to incorporate some objective measure with a validated or some kind of assessment tool to then objectively figure out what those symptoms are manifesting as, so that you can then use those side by side and say, okay, so I gave this shorter acting drug at this time point, and after X number of minutes or hours, the patient's score is worsening. So this is my trigger to give additional doses. Now, if you do that for a few rounds and the patient's scores are continuing to worsen, then I think that can be a good hint that perhaps the patient is not responding to your current therapy, and perhaps you may consider optimizing the dose or considering alternative therapies altogether.
I really like that strategy, because I think especially for those who deal in the ICU world, sometimes these patients can be really tricky to deal with, and sometimes you don't realize that they're a kind of benzodiazepine resistant alcohol withdrawal until it's almost too late, if you know what I mean. Like so making sure that we're monitoring and following these people up front to be sure that we're treating them kind of the safest and most appropriately is really going to help you in the long term.
For sure. And it takes a village, right? So I think a pharmacist cannot do this alone, and neither can a nurse, or neither can a physician or an APP. So it is important to just bring everyone on board and get the whole team in the mix of nurse and doing the assessments, but also the pharmacist providing the expert drug recommendations to allow for optimized pharmacotherapy across the board. So you said it perfectly.
Now, we keep mentioning these symptom triggered and giving medication based on a score or a scale. So I'm sure many people might be wondering, hey, what's this score scale tool we might be using? So a common monitoring tool that I think many of us use for alcohol withdrawal disorder is the CWA-AR scale. Frequently referred to, you may hear it throughout your hospital or health system as CWA, for symptom triggered treatment. Now, what goes into this specific scale, and are there any big limitations as to why maybe there might be other scales that places might be using?
I think this question, like all the other questions, are tricky and not straightforward, but we can do our best to at least provide some objective information to guide our listeners. So the CWA-AR scale, as you highlighted, or generally called the CWA scoring tool, integrates an assessment of 10 discrete components upon patient interview to reach a maximum component score of 67. So in order to utilize the CWA scoring tool, Nick, the patient must have a history of recent alcohol use, but also they must be able to communicate in order to answer specific questions. As you can see, this may be challenging in patients who are intubated or have an alternate reason to be disoriented, such as patients with neurologic injury, which we see all the time. It is important to also recognize that the intent originally of the CWA scoring tool was to be used as a triage tool to figure out where a patient should go based on severity of alcohol withdrawal. Many of the studies that have evaluated CWA have also excluded patients with seizures, which is an important sign of severe alcohol withdrawal and should be taken into consideration. So to date, there is still no definitive guidance on which assessment tool is best for critically ill or intubated patients, but at least the CWA is one of the few validated tools we have to use for assessment in the setting. And oftentimes you see that in patients who may not be able to objectively answer certain questions because of some of the aforementioned reasons, such as in patients who are mechanically ventilated, you might see that the MINDS assessment tool may be a reasonable tool, either used in place of the CWA, or sometimes you see that the CWA plus another tool such as the sedation agitation scale or SAS, or the Richmond agitation sedation scale or RAS, is used concomitantly when patients are no longer able to communicate. So I hope I provided some less confusing but brief context as to the historical perspective of the CWA assessment tool, but also some other considerations and other tools that one can consider in select critically ill patients.
I mean, I thought that was a fantastic summary, and you hit the nail on the head in that the CWA scale really depends on the patient to be able to answer and participate in this. And I think all of us are familiar with our extremely sick alcohol withdrawal patient. They're not really just going to be able to answer 8 questions in a row very easily. And so I think that's the really big benefit of the MIND scale. And then the other kind of area that I really like to highlight is that the CWA scale, seizures are not addressed at all. One of the biggest things that we're trying to prevent with alcohol withdrawal. And so somebody could be seizing from alcohol withdrawal, and that's not going to show up on the CWA scale. So it might not reflect their true severity of illness. Whereas when you look kind of comparing to the MINDS scale or tool, it does. So I think that's one of the kind of, in my mind, one of the biggest differences that I also like to highlight.
Correct. And what would be interesting, and maybe perhaps an opportunity to fill the gap in the literature in future times, is a comparison of both assessment tools objectively in some kind of prospective fashion to get us an idea or provide some guidance. And we also need further robust literature validating the MINDS assessment tool in critically ill patients. But I certainly think there's more to come on that.
Now, one of the, I would say, I have hottest written down, but I'm going to say like scorching hot, just on fire topics in critical care right now is the use of phenobarbital for alcohol withdrawal. I think in when you go to critical care or emergency medicine conferences, I think you're bound to find at least one talk or some sort of discussion on it. So how does phenobarbital work in this specific patient population?
Yeah, Nick, it's definitely a hot button, and it certainly has gained traction over time. And maybe perhaps we can talk about some of the interesting findings in the survey we did towards the end regarding this. But phenobarb or phenobarbital is an attractive option because in addition to binding to the active site of the GABA receptor, thereby prolonging the duration of the chloride channel opening and subsequent inhibitory effects, it also antagonizes NMDA receptors, which we know from our previous discussion are upregulated and excited during the alcohol withdrawal phase. Additionally, phenobarb has a lower addiction potential given its longer half-life, and generally when it's administered, the initial dose should be administered prior to implementation of a benzodiazepine therapy if that is used. From a dose and approach, I guess we can get into that. Front loading with doses up to somewhere 15 milligrams per kilo, and even sometimes higher, up to 25 milligrams per kilogram patient's actual body weight have been used in some cases, and then followed that by a gradual taper and fixed doses, although when utilized as an adjunctive therapy with benzodiazepines based on the patient's symptoms, has been shown to decrease the rate of progression to mechanical ventilation. So there is some data that supports phenobarbital use in this setting. However, it's not without side effects. Oversedation and respiratory depression, especially when used concomitantly with high doses of benzodiazepine infusions or doses, patients often require high doses of benzos due to the downregulation of benzodiazepine receptors that present in the setting. So phenobarb can be a potentially tricky drug and sometimes confusing for providers to use. Its role in therapy generally is that initially in high-risk patients or patients with non-severe symptoms, it might be an ideal agent. In patients with benzodiazepine refractory alcohol withdrawal, as we talked about previously, how that's also confusing to ascertain, phenobarb might be a reasonable second-line option for patients as an adjunctive therapy. There is no clear advantage of phenobarb, however, as an alternative agent to benzodiazepine therapy. So it's important to note that it is not a first-line agent by any means at this time. But we also know that we need more data, more robust data, really comparing the two to see if we can potentially justify its selection based on its ideal PK properties that we highlighted before.
And I think one of the questions that I have when I think about phenobarbital in alcohol withdrawal is the dosing. And you mentioned it can be anywhere from a weight-based dose, up to, like you said, the 25 mg per kg. I see 10 mg per kg a lot too. But then you'll also see more of like the fixed dose where you might do 260 milligrams once, and then you kind of do, 130 or maybe 65. So how do we, in thinking about not only getting the appropriate dose, but also making sure that we get this medication to these patients in a timely fashion, How should we be dosing it, or are we still trying to figure out our best, most evidence-based dosing strategy for phenobarb?
I think the straightforward answer is that we don't know what the optimal dose for phenobarb is. And a few things that one should consider is where you given this drug at. So if you're given the drug in a location that has the drug readily available, then it might be reasonable to optimize it based on what's been studied with the front loading of the 15 milligrams per kilo. But operationally, that has to come from somewhere. So if pharmacy has to, or the pharmacist has to make it in the IV room and send it to the patient bedside, time may be critical and maybe perhaps not ideal. So that's when you see the other doses that you highlighted in more fixed doses, where it might be readily available in your emergency department or in your critically ill patient care area. So the jury's still hung on that, and we hope that maybe there will be further prospective studies really looking at optimal dosing strategies in this setting, and perhaps we'll get some answers in the near future.
I think this question in our poll and survey probably surprised us maybe the most, because there were two things that stood out to me when we kind of asked if your institution utilizes, phenobarb for the management of alcohol withdrawal disorder. And I think, it looks like around, anywhere from a third to half don't really routinely use it. But what stood out to me is there are lots of institutions that use it without restrictions. You can just use it anywhere. And I'm thinking of using phenobarb on a med surge floor where the nurse has, 6 to 8 patients. It seems like, based on some of those adverse effects you highlighted, specifically like respiratory depression and things, that, making sure we have safe monitoring parameters in effect, definitely would be a really good thing, especially if you're not having restrictions to where it can be used.
Absolutely. What was striking to me, Nick, and one of the critical care polling questions was that 25% of respondents, so I believe 17 out of a total of 67 people or institutions who responded, again, as you highlighted, you use phenobarbital, in a load-in dose plus a taper in select patients throughout the institution without any restrictions to patient care area. And as you highlighted, the safety concerns that should be considered, I think also operational considerations. So if you have a 1,000-bed hospital and you're allowing phenobarb to be used widely throughout the institution, you can see how that could be an operational challenge for pharmacy departments.
And you highlighted, I did not do a good job of kind of breaking down, but we had, on Twitter polls, you can get different respondents for different questions, but we had around 160 responses and a really good breakdown in this survey between, community, academic medical center, private community, and the majority of the respondents work in a MICU or a mixed ICU, which is where classically a lot of these alcohol withdrawal disorder patients might go. But yeah, definitely the phenobarb was definitely a little bit of a surprising answer. But I think, just like you highlighted, I think we're really trying to still work out and iron out phenobarb's true role in this disorder, as well as how to best use it, potentially as monotherapy or an adjunct with some of our other treatments.
For sure.
Now, I think an issue that can drive many pharmacists crazy, and when I say many pharmacists, it might be just an N of one, which would be me. But I think it can be a problem in a sense when dexmedetomidine is being used for alcohol withdrawal treatment as monotherapy. So what is the role of dexmedetomidine in alcohol withdrawal, and what has it been shown to do?
Yeah, that's a good one. And I think you're maybe perhaps have another person in your company, so maybe an N of two. But you're absolutely correct. The main role for Dex or dexmedetomidine is that it possesses anxiolytic and sympatholytic properties that attenuate the autonomic hyperactivity. So dexmedetomidine itself does not address underlying physiologic deficits that we see in alcohol withdrawal disorder and should not be used monotherapy. Its role is that it can be used or considered as an adjunctive agent in patients who continue to exhibit symptoms despite optimal first-line therapies. Dexmedetomidine also can cause bradycardia and hypotension, especially with loading doses there, and it does not prevent withdrawal seizures, so you can see how that can also be dangerous. There are several retrospective studies that have looked at dexmedetomidine as an adjunctive therapy, and all of them have generally found that it may reduce benzodiazepine requirements, so that's a good thing for that. There was a single prospective randomized double-blind placebo-controlled study by Mueller et al. In 2014. Nick, the study looked at about 24 patients, so 8 patients in each arm. One arm used a fixed dose of dexmedetomidine, which was considered the high-dose arm, and the dose selected was 1.2 microgram per kilo per hour. There was a low-dose arm, which utilized 0.4 microgram per kilo per hour, and then the third arm was the placebo arm. In this study, both the low-dose and the high-dose groups had marked reductions in benzodiazepine exposure when compared to the placebo group. So in terms of additional items to help guide appropriate dexmedetomidine use, I think optimizing provider ordering, because as you highlighted, use monotherapy is not appropriate and can actually be dangerous. So how can we guide our providers in selecting the drug for the right indications with the appropriate first-line therapies already on board? So we can optimize ordering by including things like indications for use with perhaps passive alerts to drive prescribing, and we know that has been successful in some institutions, including mine.
And what a great study that you highlighted from a lot of our pharmacy colleagues from the University of Colorado, who did this great study. And the biggest thing is that it's a GABA-mediated disease, and if we use dexmedetomidine monotherapy, we have no GABA activity. So that's, you highlighted all of my concerns, and I'm glad that I'm not the only one that gets frustrated when you see somebody who's in alcohol withdrawal that's only gotten Dex for 30 hours since they've been admitted to the ICU.
Yeah, you're definitely not alone in that. And I'm sure majority, if not all of our listeners, are probably with you on that one.
I think from an ease of therapy, I think some people may do it just because you can, it's one of those where the theory is that they could just titrate the dexmedetomidine rather than having to do the CWA scale, right, every hour, or the MIND scale or what have you. That can obviously be time consuming and things, but there's always trade-offs when we do those types of things.
Absolutely. And oftentimes the best thing is not the easiest thing to do. So
the older I get, I'm learning that it's typically it's almost never the easiest thing, unfortunately.
No, when it comes to alcohol withdrawal, definitely not.
So we're kind of in the area now of some of our adjunctive therapies. So another one, obviously we can't have a critical care podcast and not talk about ketamine. Oh my gosh, are you kidding? So, ketamine.
Let's talk about it.
And, ketamine has some pathomimetic properties. And so in this really excitatory disease state, it almost seems counterintuitive to use it in alcohol withdrawal. But can we use ketamine, or should we use ketamine for alcohol withdrawal disorder?
Yeah, let's talk about ketamine, or Special K, I call it. So ketamine is a dissociative sedative. You highlighted its mechanism. So it's a non-competitive NMDA receptor antagonist that ultimately blocks glutamate. So it mimics the effects of alcohol at this receptor, Nick. And if you recall what we described previously, during the acute phase when this is happening, this might actually be something that could be helpful. Ketamine also additionally has the ability to be rapidly titrated to effect, and it also lacks respiratory depression even at high doses. So you can see how this could be an ideal agent. Um, Generally, when ketamine is used, an infusion is what has been noted to be helpful. So specifically, ketamine infusion in this population, so patients who present with alcohol withdrawal disorder, has been associated in the literature, not robust, but in what we have, with reduced ICU stay, also lower cumulative doses of benzodiazepines, but also reductions in intubation rates. However, all of the available studies I have to disclose are retrospective in nature, and the samples are super small. So, for example, in 2015, there was a retrospective study that looked at the use of ketamine, not monotherapy, so I have to clarify, as an adjunctive agent to benzodiazepines in acute alcohol withdrawal in only 23 critically ill patients. So this small study also supported the concept, as I highlighted before, that ketamine can reduce the amount of benzodiazepines needed to manage alcohol withdrawal acutely. So generally, infusions can be helpful when administered together with conventional or standard managements for the management of alcohol withdrawal.
So we're keeping this kind of in our tool belt for our really sick kind of refractory alcohol withdrawal patients, and maybe not necessarily kind of in our first line treatment options.
I would say so, because there is no consensus on even how to dose it or when to start it, right?
Mm-hmm.
And ultimately, because of the lack of robust data, all available studies, I think I highlighted, are retrospective in nature, and there are better drugs, no direct comparison studies to my knowledge. There are also cheaper drugs. So I think as a pharmacist, we have to think about all of those things and look at the literature. And when there is not another superior or inferior, or there are comparable agents with the limited data, we always have to go with what's cost effective and what's better for the patient ultimately from a safety standpoint as well. We also have to consider operational aspects. So I think I agree with you wholeheartedly that this would not be my first or even second line option for the management of alcohol withdrawal disorder.
So you alluded to earlier that sometimes our most sick patients with alcohol withdrawal disorder have to get put on the ventilator, right? They may need too much, medication or sedatives that can impair their, cause respiratory depression or altered mental status, or they're just so agitated there, you have to intubate them just for airway protection, right? Or whatever reason kind of happens. And I think for patients who are on the ventilator, Propofol is an adjunct treatment for that may be considered in some of those patients. So what is Propofol's role kind of in alcohol withdrawal? And is there any evidence to say that we should be using this as monotherapy compared to adjunctive therapy?
Yeah, so we all know Propofol. It is everywhere in our ICUs, and almost all of our mechanically ventilated patients are on it at some point in their ICU stay. We love Propofol because it's rapidly titratable and, as you know, provides an ability to achieve light and deep sedation dependent on the dose. So it's universally used in critical care space, and its mechanism of action, specifically GABAergic and NMDA antagonism simultaneously, make it a super attractive option for patients in the setting of alcohol withdrawal disorder. Studies have looked at Propofol for alcohol withdrawal disorder in general critical care patients, and it's also been studied with and without benzodiazepine therapy. So first, in general, withdrawal scores do not significantly change over time when Propofol is in place, especially by itself, except perhaps early on in therapy. But we also learned that the use of Propofol may slightly reduce or even have no effects on the need for benzodiazepine therapy. There is some signal, though, that Propofol may be helpful in patients who are refractory to benzodiazepine therapy. So for its role in therapy, again, like ketamine, Propofol wouldn't be a first-line option, but perhaps a consideration as an adjunctive therapy in patients who are benzodiazepine refractory. And I think if I had to pick Propofol or Dex, I would consider it after dexmedetomidine.
Why? I'm not sure I was expecting that. I don't disagree, but I like that. I like kind of putting them in a little kind of adjunctive power rankings there. I like that. Now, no, go ahead.
And I think the reason for that is that the literature for most of the infusions we see in this setting are not robust. Mm-hmm. And so one has to think about, well, how do they compare from a safety standpoint? We know that prolonged infusions of propofol has unintended consequences, including PRIS, among other things like pancreatitis. We also know that Dex is relatively safe, aside from the bradycardia and hypotension that I highlighted with the bolus doses. We also know that these agents can be used as adjuncts, and when we do them together with our first-line therapies, generally, we see some reduction in the amount of benzodiazepines that we expose our patients to. So recall, do no harm, and we want less drugs overall for our patients. So that I think is my justification for why I think dexmedetomidine might be more ideal than propofol in this setting. That's an adjunctive therapy to standard therapy for the management of alcohol withdrawal disorder.
Now, another surprising result to me was from the poll and survey was the use of valproic acid and gabapentin. I'm not saying that necessarily using that as combination therapy, together, but they received a lot of support from the poll and survey as adjunct therapy for alcohol withdrawal disorder. Now, we'll kind of, I threw two drugs at you here, but we'll kind of potentially go one at a time. But what is the evidence for valproic acid or Depakote and gabapentin for their use in alcohol withdrawal disorder?
Yeah, I was also pleasantly surprised to see the number of respondents who are actively using both agents with some confidence for the management of alcohol withdrawal disorder. I think if I am interpreting the results correctly, over almost 55% of the respondents in the critical care listserv survey did assert gabapentin as one of the primary adjunctive therapies utilized in the setting. Similarly, over a quarter of the respondents utilized valproic acid when adjunctive therapies were in play here. So let's provide some context additionally to the survey respondents. First, valproic acid or sodium valproate, in addition to its anticonvulsant properties, which we know is critical and necessary in this physiology of alcohol withdrawal disorder, valproic acid has proven to have mood stabilizing and or anxiolytic effects with GABA potentiating mechanism of action, which makes it an attractive agent in the setting. So what does the literature tell us? As you probably expected, the studies for either valproate or gabapentin are not robust. So for valproic acid, however, there was a small study of 36 patients, but it was prospective, randomized, double-blind, placebo-controlled. The study looked at valproic acid dosed at 500 milligrams 3 times daily for 7 days in patients who presented with a CEWA score of 10 or greater who were also receiving concomitant benzodiazepine therapies. Valproic acid in this setting was compared to patients who also received placebo concomitantly with benzodiazepine therapies. What they found was that patients who received valproic acid had less benzodiazepine exposure, but also experienced less worsening of symptoms, meaning their CEWA scores did not escalate or worsen over time. We also know that valproic acid is relatively safe, especially when it's monitored and not used for a prolonged duration. However, we must highlight that it has some side effects that are noteworthy, specifically hepatotoxicity, transaminitis, hyperammonemia is sometimes seen with high doses or prolonged exposure, and theoretical cytopenia. I say theoretical because there is conflicting literature that asserts this side effect. And these are some potential safety considerations of valproic acid. So now let's shift gears a little bit to gabapentin. Of all of the adjuncts, it is probably the most safe, I think. Primarily, gabapentin modulates GABA through the suppression of membrane depolarization. Typical doses that have been studied go up to 2,400 milligrams in divided doses, which is usually given within the first 24 hours of patient presentation and initiation of first-line therapies. And this is usually followed by a gradual taper. And this dosing strategy appears to be the most effective when used as an adjunct therapy. So I think if a patient comes in on it, so a patient is home on gabapentin, and they come in, and this is the agent that one decides to use and maintain, there may not be robust data, but it makes sense to perhaps optimize the dose into what we know has been helpful in the management of alcohol withdrawal. And it would not be unreasonable to continue this for that duration of therapy and then go back to what they were on at home before they get discharged.
So kind of summarizing what I took away from that is that it sounds like, especially for patients who are experiencing alcohol withdrawal and come to the ICU, gabapentin might be one of those adjunctive agents that can kind of be, on that order set for the ICU admission, where, those patients can come in and it can really help improve some of their care. Whereas valproic acid, although yes, it certainly can do a lot of those things, just based on some of the side effects, that might not be an agent that we want to use for everybody all the time.
I think you said it really well. The one thing that I would note is that it gets sometimes tricky and difficult to incorporate some of these therapies into an order set. One has to consider things like enteral access for agents like gabapentin. So if this is the route that a pharmacist or an institution pursues, it will be critical to provide guidance to providers as to when it is appropriate to select some of these enteral therapies versus other agents that may be able to be administered as injectables. But you are absolutely correct. Gabapentin is fairly safe. It is effective, at least in the limited literature that we have, and would be a reasonable adjunctive therapy in this setting. The one thing, Nick, I also wanted to add that gabapentin does not appear to be effective at treating withdrawal seizures. In studies that looked at gabapentin, patients continue to have breakthrough seizures in the setting of gabapentin use for alcohol withdrawal. So if it is incorporated into an order set, I think some decision support will be important to note there, or some informational text for providers to let them know that this would not be optimal in patients who continue to have seizures in the setting of alcohol withdrawal.
Oh, I think that's a really important point to kind of highlight there. So thank you for that. You've done such a great job of reviewing and giving us a great overview, especially into the pharmacotherapy of a disorder or syndrome that can have widely ranging signs and symptoms. But what maybe advice or tips and tricks would you give to pharmacists who are looking to kind of create or revamp some of their alcohol withdrawal, guidelines or protocols, or corresponding kind of decision support tools in CPOE in their EHR systems?
I say get creative. There are so many options, as we've gone over in the last hour, that have promise for the management of this syndrome, especially in our critically ill patients. We know that there are no universally accepted guidelines to date for the management of alcohol withdrawal disorder. So this is where we excel as pharmacists to really get creative and look at the literature, bring in our expertise, and provide guidance as to what would be the optimal agent sequentially in this setting. there are studies to guide us. So we also have some validated assessment tools that we can consider in development of guidelines or protocols. I have to highlight, though, the American Society of Addiction Medicine published some guidelines earlier this year, and I actually really like them. The guidelines are to be used in the setting of patients who are ambulatant, so in the ambulatory setting, but also in the inpatient setting. They provide recommendations for identification and diagnosis of alcohol withdrawal disorder. They also provide guidance for initial assessment that includes a comparison of the different assessment tools that we talked about within the last hour. And then finally, they provide guidance and recommendations for patients who may be not hospitalized. So some pharmacists may be practicing detoxification centers who may benefit from reviewing this document, but also they provide guidance for our critically ill patients who are hospitalized. So that would be a good reference to give you a bird's eye view as to what the assessment tools, the pharmacotherapeutic agent, and some of the general challenges that one should consider. But getting back to your question about how one goes by creating a guideline or a protocol or optimizing the CPOE, it's important to first understand current practices and perhaps comparing how you're doing at your institution to other peer institutions or surrounding sites. I would also highly consider seeing which agents your hospitals are currently using and how they're being used, so then you can target your interventions better. If one wanted to create a guideline or a protocol or some resource, maybe pilot something and then perform a quality improvement assessment and then tweak it until you get it right. Would also consider incorporating an assessment tool directly into your computer system if feasible, and would highly encourage including or engaging nursing colleagues as champions for this effort, because they're going to be doing the assessment tools. We talked about how it is important to provide some objective screening or assessment to guide when to repeat doses, for example. Do not incorporate, finally, beer or wine or whiskey into your alcohol withdrawal management if you decide to create a guideline or protocol. So I think those would sum up what I would recommend to any pharmacist who is looking to create or revamp their alcohol withdrawal guideline.
Oh, that's absolutely fantastic knowledge and advice for everybody listening here. So I really appreciate that. Now we're winding down in terms of the year. We're kind of in that holiday period between Thanksgiving and Christmas. Now let's step back to Thanksgiving for a second. So what would you say, because there's plenty of options for food. All of us were full yesterday. What would you say is your favorite Thanksgiving side?
That's a tough one because I love to eat. But I will say my sister makes the most amazing sweet potato casserole. So it would have to be that. I think I ate by myself half of the entire the plate. But I would say that's my favorite thing to eat as a side item during Thanksgiving.
Is it well known within the family how much you love it? Like, are they making an extra portion of that dish specifically for you and your stomach?
If I have to answer that assertively, that's probably the bad side. But yes, most people are a little bit conservative when they make their plates when they see me around.
Okay, and then we're getting into I think I've heard Christmas music now for about the last 48 hours. So I think we're officially in the season. So what would you say is your favorite Christmas song?
Something by Leona Lewis. She has the most angelic voice. I think I really like Oh Holy Night by her, at least in the last, it came out maybe like 7 years ago, and I've listened to it on repeat a few Christmases since then, and I think that's got to be my go-to. How about yours?
I would say my favorite is probably the Bruce Springsteen version of Santa Claus is Coming to Town. Oh, I just love it when he rocks out. But the one that just stands out that I think is just incredible, and they took it off of Spotify, but if you go on YouTube, there's a Rudolph the Red-Nosed Reindeer that's performed by DMX.
Yes.
And it is as amazing as you expect if you have any idea who DMX is, if you're listening, which I'm guessing there are listeners who have no clue who that is. But if you have any clue, go to YouTube, listen to it. It's one of those that like I could listen to it on repeat because I'm just in awe of it, to be honest with you.
I agree, but you have to be careful when you play it around people who haven't heard it before.
Oh, that's very true. That might be one that you pop the headphones on to give it the 2-minute listen first. Yeah.
Precisely.
I think there's only one wrong answer here, and it's Mariah Carey's All I Want for Christmas. And I know there's people that felt attacked right there. The first 100 times I listened to it, it was great. But now that I'm on time, probably 9,000, I'm just, it's run its course for me. But I'm assuming I'm going to listen to it another 100 times like we probably all will during this season.
And I'm sure there's multiple remakes of that. So you can switch the artist if you get tired of hearing her voice. Don't attack us.
Well, Kent, thanks so much for coming on and joining me. For all the listeners out there, Kent is on Twitter at TigerNole13, TigerNole13. I love the subtle shout out to both of your alma maters and your Twitter handle.
You got to do it. You got to do it.
Well, Kent, I appreciate you. I'm glad you had a good holiday, and hopefully we're able to wrap 2020 on a good note.
Nick, it's been an absolute pleasure. I enjoyed talking about this disorder. I'm no expert by any means, but it certainly was a good learning experience for me, and I'm happy to share my thoughts. So thank you for that, and I hope you enjoy the rest of the 2020 year, and happy 2021.
Yeah, absolutely. And, thanks again to Kent for being our special guest today. And as always, please send me feedback, both positive and negative, as well as any guest or topic ideas. Twitter at PharmacyToDose, or via email, PharmacyToDose, that's TO2dose @gmail.com. And on our website, PharmacyToDose.com, you'll find show notes as well as a reference list. And, these links are available on the website, and they're also embedded within the episode description. So until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast.